Hey, how's everyone doing today? It's John Delossantos, JMD Healthcare, and we're here today to give you this great informative webinar regarding the 5-star rating. Now, before I start, I just want to tell you a little bit about myself. I'm a 22-year veteran in the skilled nursing facility industry. I was a 15-year veteran of the largest privately held contract therapy company in the country. I'm a registered occupational therapist. I'm a ANAC certified resident assessment coordinator. And I also have a ICD-10 coding certificate from ANAC that has to do with skilled nursing facilities and the diagnosis coding. I sit on the advisory board for 2 colleges, and I've overseen over 40 regional managers and over 2,000 skilled therapists. So I've been around a little bit. Now, a little bit more about JMD Healthcare here. We are a brand new service to the industry that gives you a better option, in some cases, most cases I would guess, than contract therapy. You know, our RAM service is the best of both worlds. It gives you the oversight and the accountability that's required to make sure that your therapy team does everything they need to do to get your patients the outcomes and the facility the reimbursement that they deserve, but they don't charge you for the markup, so they're your own staff. You know, it's not really necessarily an in-house program, but it's kind of a mix between the two because you still get the management service. Now, not only that, but you get the PDPM expertise. We are the PDPM pros. So to have those two things together is something that no one has ever offered, and quite honestly, it's one of the most valuable things you can have in your building. Not even just because of the PDPM expertise, but saving for the cost factor of the contract therapy. I'm telling you, it's a good service. If you're ever interested, give us a shout. We'll gladly talk about it. This isn't a commercial. This is a webinar. So we're just going to jump right into this today. Today's objectives is, number one, we want to understand, you know, why the 5-star rating was established. You know, what was this for and how are we using it? Number two, we want to understand why this is so important. Because it is, by the way, especially after COVID. We'll get into that later. Number three, understand who looks at this stuff. You know, is it just CMS? Is it just some big database, some giant spreadsheet you can download? Or are there people really active in looking at these things to kind of determine where they're going to send their loved ones? Number four, you need to understand how this is calculated. And it is a little bit of a complex system when you first look at it, but once you break it down, it isn't nearly as hard as everyone thinks. And there is a very, very easy way to predict where you're going to be with your 5-star without a lot of mathematic calculations, and we're going to get into that later. Review ways to improve that 5-star rating. That's kind of what I was hinting towards, that there's definitely some areas that you can focus on to get this moved up quickly or avoid it dropping quickly. We'll cover that again later. And then at the end, I'm just going to kind of throw out there the impact that this COVID-19 pandemic has had on all this. You know, it's been a really crazy past 9, 10, 12 months, especially when you're trying to start a company. So I can tell you that there's some things that happened with this system because of COVID. And some things that actually changed what we really thought it was going to be. But you need to know what's going on because it's a very competitive industry. And I'm trying to stop myself, but we'll get into a little more of that later. All right, so, you know, when did this all start? You know, CMS launched its 5-star rating system for Medicare and Medicaid in December of 2008. So that was quite a while ago, and everyone seems to know about this. So this isn't a new concept by any means. The system awards stars in 3 subcategories to determine an overall composite star rating, which means, hey, you kind of look at it, kind of like when you're on Amazon and you see people's reviews. You know, people are reviewing your facility based upon the star rating. And it's not a bad idea, but I think a few more people need to get focused on it. And why? You know, why are we doing this? And it was created to actually help customers and families find nursing homes that fits their needs. You know, the things they focus on, the things they're good at, because it actually takes into consideration some of the quality measures, some of your actual treatments, your MDS data to determine what you're good and what you're not good at. So that's supposed to give people an idea. And, you know, it makes sure people that they're holding themselves accountable. You know, it encourages nursing homes to make sure that they're focused on these things so they don't have a bad reputation, because that's kind of what it leads to. If you don't have this 5-star rating, you're known as a bad facility. And now they've even slapped some more labels on there we'll get into later that even make you look worse. Some make you really stick out like a sore thumb. And quite honestly, in this competitive market, you don't want that label. You're gonna have a really hard time moving forward. So again, it is important. There's reasons why these things are in place. So let's just talk about them and see how we're going to look at them. Now, I just want to read you something really quick. CMS urges every American to consult their doctors, their families, and their loved ones, and nursing home compare before they make any decisions about nursing home care. And that was said by Kate Goodrich, who is the former Chief Medical Officer for Medicare, Medicaid services. Now see, they're making a point to tell people you need to look at this before you send your loved ones there. That's how important this is. That's how much they believe in this. And when it comes from someone that's in charge of the regulations of your facilities, people listen. So it's important. And there's another reason why it's important. In today's society, we all know we're carrying around this supercomputer in our pocket. And before you do anything, someone tends to Google it, okay? So when they Google your facility, they're gonna come across this 5-star rating. And when they see this star rating down by the 1 or the 2, I hate to tell you, they're not going there. And they're not calling you, they're not asking you, they're not stopping by. You'll never know they are interested. 1- and 2-star facilities obviously have had some issues in the past. Sometimes when you score these things a little, it's kind of hard to come back, and I think it's a little bit unfair when you get down that low, because you really have very few things that can get it back up at first, and we're going to go over that later. But it's just a fact. People look on the internet before they do anything else nowadays, and it's very, very important that you get your 5-star rating where it needs to be. And because the way the system's set up, it goes on the percentages. There is no number to get you to that 5 or that 4. It actually works off the percentages of the other nursing homes in your state, okay? So you need to get ahead of the game, or you're gonna drop without even doing anything wrong, just because everyone else is picking it up. That's why this system it seems so complicated, because there is no number to shoot for. It all depends on how all you guys shoot for it. So let's start getting into this so you guys can understand a little bit more what I'm saying. And of course, I know some of you already know this stuff, but some people are confused about the 5-star rating. They really are. I was confused about it until I really dug into it, and it's a much cooler system than I thought. They put a lot of thought into this stuff. Okay, so how is this 5-star system calculated? Let's start with that. There's 3 components. There's your health inspections, quality measures, and your staffing. Those are the 3 things that they kind of pile together to determine how well you're doing, okay? So, on your health inspections, all right? To find this portion of your rating, scores of the state-conducted health inspections, state surveys, are combined with the deficiency rating and the number of substantiated complaints, okay? So basically, your annual surveys, any of the revisits, any of the follow-ups, all this kind of gets calculated into your 5-star. And what I say, this is like your base. And I want you to remember that, because this is the base of your score. So that already tells you how important it is. I'm not going to get into it yet, but remember that. This is the base of your score, okay? And I just kind of jumped ahead of the game here because I want to reiterate that idea that the scores of all senior care facilities in the state are then graded on a curve, okay? The top 10% receive 5 stars. The bottom 20% get a 1-star. Like I said earlier, you may have been a 2 or a 3, and all of a sudden, oh my gosh, boom, I'm a 1. I didn't even do anything. I mean, my scores were all the same. I didn't even do anything. Doesn't matter. Everyone else is picking it up. You're falling behind. Just like what they say in business. If you're not moving forward, you're falling behind. That's how the system works. You got to understand that, because you always have to be looking at it, because there may be a whole group of other facilities that are moving ahead while you fall behind, all right? Now, the middle 70% are divided into 3 sections: 23.33%, right there on the screen, and they're awarded the 2, 3, and 4. So those are like the middle group, the mid group. But again, you could have been a 3 or a 4, which is pretty good for, people are going to be interested in the 4. Then all of a sudden, boom, you drop to a 3, and you got everything else. I'm not going to get into how they score it yet, but say your scores were almost identical, but you've dropped to a 3, and you're like, hey, what did I do? You didn't do anything. That's why you fell, because everyone else is doing something, and they're moving up. That's the way things work. You got to keep with the pack. So this is going to be very important in the very near future, especially after COVID, when all these censuses are hurting so bad. You need to get a handle on this so you don't fall to the back of the pack, because you're not going to get hardly any Med-A patients, skilled patients, and you're definitely not getting the good ones. So if you really want to keep competitive in this market, you need to be able to do this and be able to keep track of your 5-star and make sure it's not dropping. And keep track of others, by the way. Okay, so the second piece of this, your quality measures, all right? CMS uses 10 MDS quality measures and 5 claim quality measures to rate this portion of the overall score. These measures include 7 long-term, okay, and 3 short-term. So long-term, obviously, people that are staying there extended. They do set numbers to this, 100 days, but people that are really living there, for good because they need the help. And then the short-termers who are there for a brief stay to get better, go home, or assisted living, or decide where they're going to go. Okay, so they want to look at both of those, and that's a great idea. All right, these measures are a broad range of function and health status indicators, data from the MDS quality measures, and these hospital-based ED, that's emergency room, I don't know why ED, but ED visit measures are updated quarterly, and the QM rating is updated at the same time. So every quarter, they're going to take these, I guess, questions or the things that they're most concerned about, give you a percentage of how you're doing based on who's in your building and who was eligible and who actually triggered for these things. You get a percentage, tally these things up, and we're going to show exactly how that works. Tally these things up, and then they decide how you get your 5-star, and it's supposed to be an indicator of how you're doing. So remember, I already said MDS, and being a therapist and being a PDPM pro, I can tell you right now, the MDS has never been more important as it is right now. It's a huge part of your payment, and it's a huge part of how people view your facility. You need to get a handle on your MDS now. Not later, not sometime, now. Because this is how you are going to be graded on a go forward. And people are getting better at it, I must admit. They're getting a lot better at it, but there's still some work that has to be done. All right, number 3, your staffing. Okay? And staffing is a direct indicator of care. They've been saying this for years. So now they're going to make you prove it. Okay? The method by which the RN staffing and the overall total nurse staffing ratings are combined is changing to provide more emphasis on RN staffing. This is when they made this latest change, and they're more focused on the RN because they feel like that registered nurse is a crucial part of your facility, which it is, by the way. Okay? Now, the overall staff rating is based on a combination of total staffing and RN staffing ratings. But RNs kind of have their own thing. Just because they're the ones that handle more of the complicated medications, or do some different assessments, injection, IVs. There's a lot of stuff that RNs do that is very, very, very valuable. And obviously, they don't want people trying to cut cost corners by having lower educated nurses just to save, because an RN makes a little bit more, obviously, more education, more abilities, more skilled services. So you need to have your RNs in place. So now they made this a priority, and now they're making sure you have it in place, or it's going to kill your 5-star. I'm going to tell you that later. Okay, the 5-star staffing category is calculated by figuring the total staffing hours per resident day. It's important, HRD, hours per resident day, and RN staffing hours per resident day, with CMS prioritizing RN staffing levels by routing the 5-star staff towards the RN staffing rating. So if you really, what that basically is telling you right there, if you really screw up on your RN staffing, you really screwed up on your staffing. And it's really going to impact your 5-star, just your RN. So RNs are important, not only for their clinical skills, but they're very important in this 5-star rating. All right. Now, let's go over the first one, your health inspection impact, all right? Each survey cycle is comprised of the standard survey, your annual, and any revisit. So if they have to come back to check some things, a lot of times you'll get certain kind of level of tags. You're required, not requested, required to do a plan of correction. If they have to come back and relook at some things, they're going to have to come back. How you score on those revisits even get calculated into this. So you don't want a whole, not that we want revisits anyway. I think people are very relieved when the state is done. But the more revisits you get, the more it could hurt you. All right. Complete surveys follow an independent 12-month cycle, but their points are added to the closest main survey cycle for the purpose of calculating the survey cycle total points. That's a little goofy wording. This is right out of the, there's like an instruction booklet CMS puts out for 5-star. I think they call it like technical booklet. It's kind of right out. Some of these terms are right out of there, but we're gonna go over that really good. Okay, follow up and revisit surveys to ensure that any deficiencies found have been corrected. Just like I said earlier, you get an opportunity to correct some of the stuff you've done, and you actually can get some of your tags lowered in severity if you really do some really good plan of corrections. I've seen that happen, so it's worth it, and it's better for your building anyway. Each revisit beyond the first carries an additional penalty on the total points for deficiency. And here is how this little grading system, I guess. The first revisit, they're not going to give you any additional points. Second revisit, you get a 50% penalty. Third, 70%. And if they're coming for a fourth time, you're probably not even worried about your 5-star anymore. Because if they're there 4 revisits on the same survey, you got some serious issues, and care is your number one priority. Forget about your 5-star. It doesn't matter anymore. There's something going on there that needs to be fixed, so people aren't put in harm's way. So that would be your focus. But anyway, that's why those things are graded up that way. So the bigger issues you have, the more they're going to have to penalize you that. And that makes sense. I'm sure no one feels like that's unfair. No one wants a 4th survey. Nobody. Or a 4th revisit on the same survey, I should say. Okay, so here's how the deficiencies and the kind of points work. There's the chart here I'm going to show you, and this is right out of that manual, and there's going to be a link up in the downloadable information on the side of the screen here where you're going to be able to download this directly if you're interested in getting it for free. The CMS puts this out. It's directly from them. They want everyone to have it, trust me. Anyway, so you got 2 ways you're going to kind of grade how you're doing with these. You have your severity, and that's kind of like the severity is like how much of an impact, how much harm are we doing, and then you're going to have your scope, which is going to tell you basically how many residents is it or could it impact your facility. Is it a is it isolated to one person, or is it widespread among your whole building, and is it really dangerous? That would be the worst tag. Nobody wants that. Everyone hears of jeopardy because that's the highest severity concern. Jeopardy, immediate jeopardy, like your life could be at jeopardy because of these things. So that's how to grade those, and they kind of bring them together, and you can kind of see what you would get for points. And we're going to cover the points a little bit later, so I'm going to skip over that for now. All right, so like we said, the survey star rating calculation is dependent on the last 3 cycles. So your latest one, which makes sense, has the heaviest weight, which is 50%. Your second to the latest, which they call your cycle 2, the previous survey to that one, would be 33.3%. And then 3 years ago, so these things, I'm telling you, survey guys, this is the key. This is where you start. This is the base. This is what I'm talking about. Number 1, quarterly updates are for quality measures and staffing. You can update things quarterly. Look at this. You're going 3 years back. Okay? So when you start struggling with survey, you're going to start struggling with 5-star for years. So we got to get your survey right. That's where it starts. That's the base. Okay? Now, each facility's survey score is then compared to other facilities. We talked about this, how it's graded, and the state will determine that star rating. So same breakdown. Top 10%, middle 70%, and the bottom 20. It's going to all level out, and that is what's going to start giving you this star, your first base star rating that you can build or deduct from if you don't do things right with your other couple things. Build or deduct from for your final. Okay. Now here's going to be our example of our star rating example. So, say 3 years ago, June 2018, we have a G level deficiency, we have an F level deficiency, and a D level. All those have a point rating system that, and I'm going to bring up the, just so I have it up in the corner here for you guys so you can kind of reference to it. That's all based on a point system. So every level has its own points. Add up those points for each of those three, the surveys they're going to be using, the capturing, the previous one, and then that year's one. You add, and then 50%, 33, and then your last 16%. You're going to take those and you're going to put them all together, like I said on there. Your cycle 1, 2, and 3. 50%, your survey score would actually be 32, 33.3%, 28, 60%, 40. So now you're going to add those three. 33.3 will be the total for that survey score. Okay? Now, based upon, again, how your state does and how other people do, that top 10, middle 70, bottom 20, you're going to fall in some line. And in our example here, which is actually an example for a facility that we actually did, they're going to fall, right around that 3-star, right in that middle 70%. All right, just based on how that state. I can't remember what state this was. I don't know. So that's how you would grade that. And you can go into the CMS, that's like the CMS data. Maybe I'll put a link up on the screen here. You guys can go into there if you want to. And you can download all these averages they put out every quarter for you guys to compare to. And that's where you'll get this information to compare if you need it. All right? So that's a good example of how that goes, how you add them up, how you take the percentage, use that score, compare it to the other facilities in your state, top 10, middle 70, bottom 20, and then where you fall in that range is going to be your survey star rating, your what I call the base. This is what you're starting with. And I'm telling you, you don't want to start with a 1 or a 2. You don't, because that's basically what you are from that point on, especially if you come out a 1. You don't have much work to do because you really don't have a lot of options left. That's why this one, I feel, this is my opinion, is the most important one. You got to get your surveys right. Okay? All right. So, next one, staffing hours impact. All right? Let's first talk about what we touched on earlier, why this is so darn important. Numerous studies point to the correlation between higher staffing levels and better patient outcomes. Okay? Therefore, it was important to CMS to report the facility's staffing levels as part of the 5-star rating process. What they're saying is, we not only feel, but we have proven the more and better staffing there is, the better our residents are taken care of. Okay? That simple. That's why they put this in here. Okay? And if you think about it, it's probably true. The more help you have, the better outcomes you're going to have. The more help you have building a house, the faster a house gets built. Probably the better it gets built. Not as many things get missed. People aren't stretched. People aren't, you have more people that are good at different things. Focus is higher. People are watching each other. It does make sense. It does make sense. But I also understand, being in business, you have to balance how much staff can I afford and how much staff is appropriate for the care of my patients that I currently have. So there's a balance here, and this is what gives operators a headache trying to balance out these staffing things. Now, CMS assigns stars based on the facility's achievement in 2 main areas, and we already touched this. RN staffing and total staffing, which includes RNs, LPNs, and your CNAs, your nursing assistants. All right, nothing else is in here. You don't have therapy, you don't have social work. None of those hours go in there. But it's all nursing, but it does include CNAs. Some people say, well, CNAs, that's not a nurse, but they are. They're just direct care. They're more of a lower level, but they are a nurse, and they're very important to the facility. Now, I want to tell you this. People miss this. I found people missing this in the past. When I tell them, let's add up your RN hours, they'll get their director of nursing or an administrative nurse, a nurse in charge, or a floor nurse. They'll add them all up. They'll bring it to me. I'll be like, okay, are you in here? Is your DNON in here? Oh, no, I thought you were talking about the care nurses, the people that are taking care. No, that's not it. This is not dedicated only to direct care staff. This is all nursing hours you have in your building. Even if that DON is in her office all day, those are still RN hours. Those are still nursing hours in your. Some RNs are MDS coordinators. Well, a lot of facilities don't see that as a floor RN that's doing direct care. It doesn't matter. If they have an RN license and they work in that building, you can include them in your calculations, which is the PBJ, your reporting of hours. They should be included as RN hours. Now, why? Because of something. How many times have you gotten pulled? You're an MDS coordinator. Somebody calls in, you get pulled to the floor. There's something going on. They need another nurse. You're there. That's all they're looking for. Who's there? Who is available? Who is a nurse? They're not saying you got to be around helping patients all day long, direct care. But there's RNs in the building. Therefore, there's a higher likelihood situations will be handled better. And that's really the point of it. So make sure you take all the RN hours you can. If they're office hours, if they're in the building, they're to be included. And a lot of people don't kind of understand that. The nursing staffing hours reported through the PBJ, we touched on that. That's the reporting system for hours. I think we've all heard of that. And the daily MDS, they're summed across quarterly periods. So what they're looking at is MDS acuity of patients, and kind of what they feel like is important and needs, and the total hours that you have of nursing staff in the building, okay? And to normalize this, they make some like multipliers, some national averages that you're going to multiply with what you come up with in your building to make it fair for everyone. And the point of this is and this is why, again, your MDSs have to be important. Your MDSs have to give CMS a very, very clear picture of your patient's needs, okay? And the more needs they have, the more these averages will change for you based on these needs, because they understand you will need more hours to take care of people who are more needy or need more help, okay? So that's why MDSs are so important. It will actually kind of help in this calculation for you, all right? Now, so how that goes, we're going to go for the first calculation just to get your hours per day. You go by total RN hours divided by total resident days, and that gives you a very clear, the very basic indicator. How many patients did you have compared to how many hours of nursing? And that's your reported hours. Your reported, hourly nursing per day compared to your patients. All right, and that's what you're reported. Remember that the reported part is important. Now, remember we were just talking about this MDS stuff. Now you're going to take your reported hours, okay, and you're going to divide that by your case mix. Now, this is where they normalize based on the case mix, based on the needs of the patients. They normalize all this so it's fair. So for those patients who have those facilities who have very high-level patients, okay, they aren't graded the same as a person or a facility that is very dependent patients, because they need more nursing care. This is a balancing trick just to make sure everyone's on the same playing field. Then you're going to multiply that by the national average, and you're going to get this, what they call the adjusted HRD, okay? Resident or staffing hours per day. So with that adjusted amount, that's going to be your comparison factor, because now they feel like everyone has kind of been dealt the same kind of cards. You know what I mean? There's not somebody sitting with a handful of aces because they have 15 total knee replacement patients that are manage themselves, they almost dress themselves, they're very independent. And then someone else has, some patients that are unresponsive, they're in a vegetative state and they need a lot of care, or they're very dependent, they're max assistive too, they need Hoyer lifts, they're on feeding tubes, all the other hard stuff that nurses have to do, which is a lot, and they kind of balance those two things out. So it's a fair playing field. Okay. Now, calculating the staffing star rating. Staffing has 2 cut points in the matrix, and that's kind of what it comes, one side here, one side there, and you kind of find the middle, and they kind of determine this. And this is, again, straight out of that technical manual, I think they call it, for 5-star ratings. And again, you can download that off of somewhere on one of these links on the side here. All right. So you have your staff type, which is RN, or your total staffing, and then each one will have their own star rating based upon the calculations that we just went over, that we're going to go over again, by the way. This is why these on-demand things are cool, because you can actually go back and rewatch this, and then I won't have to take like 3 hours to kind of go through this. I can go a little bit faster pace, but you have the opportunity to go back and kind of go over the sections that maybe you aren't really great at, but you will know all the rest, so it's kind of great for everybody. Anyway, so you got to go through, you pick where you fell on your adjusted hours after all the calculations are done, and it will line up with the star rating that you kind of fell into. And again, these are based upon averages. They've done a really good job trying to make this fair. A lot better job than I really anticipated I was going to see when I first started doing this. They put a lot of work into this, and it's really not as complicated as it looks, but there was definitely a lot of calculations here. There was a lot of thought put into this, so that's a good sign. Okay, so staff rating is the average of the RN and the total nursing staff put all together. So when you want to get your final star, because remember we have 2 things here, we have RN and we have staffing, regular nursing staffing, but you're only going to get 1 out of this. You're only going to get 1 of those 3 pieces: inspection, your survey one, your staffing, and then your quality measures. So you're only getting 1 piece, but yet we have like 2 factors. So the way they do that is you kind of do the same thing we did before. You kind of have to level them out, and then you're going to take them together. I'm going to show you how to do that, but this is a little graph they show you in order to do that. Before we do the example, I want to go over the pieces that you need to keep in the back of your head, because there are some exceptions here. And there are some things that if you mess up on are really hard to recover from, okay? If providers fail to submit any staffing data by the required deadline, they will receive a 1-star rating for the overall staffing and RN staffing for the quarter. Wow, that's harsh. You need to turn your stuff in, bottom line. If you don't turn it in, you don't have a chance. Because getting the 1-star, and especially if you put some work into it and you have some really good staffing and not get any credit for it, turn your stuff in. Just like turning in your homework, when you're in high school, at least turn it in. Even if it's not the greatest, turn it in. But always make sure someone's on top of this. And most places are. I'm not saying that a lot of people do this, but some aren't. I don't know. It's just one of those things that you really have to make sure that you try to get done. Okay. Providers that submit staffing data indicating that there were 4 or more days in the quarter with no RN staffing hours, all right, when there were 1 or more residents, so at least there's 1 resident in there, which I'm sure most people have at least 1, in the nursing home, but it's kind of good they put in there. They put a lot of thought in this. They really did. Okay. They will receive 1 star for the overall star and the RN staffing rating. Man, that is, again, this is how important they feel this is, okay? So if you go 4 or more days with no RN hours, you're done. 1s for both. The lowest rating, the lowest possible rating you can get for missing those 4 days. You need RN staffing and you need RN staffing in your buildings anyway. You really do, for care purposes. It's very, very, very important. And there are a lot of staffing agencies out there that have emergency RN staff that will come in and help you with this. So there really isn't a ton of excuses for this. And I don't think, and by no means am I saying providers hold back RN staffing for cost. I think sometimes they're hard to find and somebody calls in sick and there's a little lack of effort to make sure that little lack of urgency to get somebody in there. So always have a backup plan, for your RN staff, just in case. You never know. I mean, there's some times where we've had to pay bonuses for people who, literally a really good bonus just to come in on the weekend, or and then the first couple days of the week because we didn't have anyone on the weekend. But you have to have it, man. This is so important. It's important for your patients too, and that they're kind of giving you that idea in your head that, guys, this is so important. We're gonna nail you if you don't do it right. It's that important to us. So just make sure you have that RN every day, and if you don't, you do whatever it takes to get somebody in there and make sure number one, the residents' needs are covered, and number two, your facility doesn't take a big punch in the gut because of a few call-outs, or a few bad road situations where there's too much snow. Things happen, man. Kids get sick. You got COVID stuff going on. That really hurts. But like I'm going to show at the end, we've done a pretty good job during COVID, honestly. So. CMS conducts audits of nursing homes to verify data submitted and to ensure accuracy. Facilities that fail to respond to these audits and those for which the audit identifies significant discrepancies between the hours reported and the hours verified will receive a 1-star rating. So don't lie, I guess, or be accurate as possible. If you have somebody else gathering this information, have somebody double check it. I mean, there's a lot of software out there that will give you this information now. That's probably your best bet. You probably don't want to rely on anybody walking around with a pencil, filling in little squares on a piece of paper anymore. There's a lot of software out there that will do this for you. And just make sure it's accurate, make sure it's submitted, and those are the first big steps to getting this process right. And and those things, those should be a given. Those things always should happen. And then the 4-day thing, it is important. So, keep an eye on that. All right, so here's the example. Here we go. Boom, watch this. Kind of covered this earlier. Total RN hours over resident, again, means divided by the total resident days. Reported hours. Kind of, you can think about this as like my raw hours, just face value, direct hours of care, okay? Now, remember, we're doing this quarterly. So when you do things quarterly, you need a multiplier to make it quarterly. So say 3 months, 30, 30, 31, 30, 31, 30, number of days, 91 days in a quarter, right? So you take that 91 days, you multiply it by your RN hours. This is the RN example. RN hours, 50 residents a day. Multiply it by 91 days. Make these things kind of even Steven. Okay, put those two things on top of each other in a fraction, divide them out, 0.652. There's your reported hours. Again, your raw data. Now, based upon your MDS, ta-da, and what care you had to deliver, you divide that case mix, okay, HRD, into your raw reported hours. And this is what's going to give you that either a bump or some kind of factor where it says, hey, their patient's really heavy duty, they're going to get a little bit extra, or their patient's really light that quarter, we're going to normalize this to make it fair. Not that many hours are needed for those types of patients. Okay. Now you multiply this by the national average to normalize this all the way across the country. Then you get your adjusted HRD. That is what counts, your adjusted. And again, those two, I'm going to link on the website here where you guys can get these hours if you need them. Okay, then you take that, write it on a piece of paper, look it on the screen. Again, there's software out there that it's not a very hard Excel calculation to figure this out, but you can line it right up, and based upon the hours that you came up with your adjusted, it's going to give you where you fall. So, fell in the range of 3 stars. That 0.508 to 0.730, right in that range, 3 stars, that's kind of where you are with that RN example. All right? I only did an RN example, guys, sorry. That's probably the more trickier one. The other one is just same deal. There's just a lot more hours because it includes all the CNAs and the LPNs and everyone else. It includes a lot more. So this one we kind of kept it a lower number, so it's a little bit easier to kind of do the math. But same thing, same deal. Multiply it by the number of days for the quarter. Boom, use the adjusted stuff and the factors that CMS has determined to be the adjustment factors, and you get your adjusted rates. Okay, so the last one, the quality measures impact. The quality measures rating is based on 15 measures of resident health covering conditions like bed sores, medications, adverse occurrences like falls and emergency visits. The facility earns points on their performance, and each quality measure and their total number of points determine their overall quality measure rating. Same kind of point system, they attach everything to points. Okay. Now, I was going to do a whole webinar on just quality measures, and then someone suggested, why don't you just do 5-star, I guess, because that is what people are super concerned about right now. Quality measures are important, but there's a lot more of them, and not all of the quality measures fall into the 5-star calculation. So I kind of carved those out, and we're kind of getting the best of both worlds again. We're going to do the quality measure, and you're going to kind of understand how that system works, but yet you can help apply it to the rest of the 5-star information. So I think that kind of actually made more sense. Because there are a lot of quality measures to go through, and as soon as you get it down, they're all kind of the same. There's some exceptions, and who's in the denominator and who's in the numerator, like who qualifies and who doesn't. But those are probably things you're going to have to look up anyway, because there's a lot of different scenarios. But these are the probably the most important ones. That's probably why they end up on the 5-star. Kind of makes sense too. So as soon as you get these down, I think you're really going to have an okay time with the rest of them. All right. Quality measures are either MDS-based or claims-based. So they're either in your billing information or scored on your MDS. And that's kind of where they get this data from. Now, all measures are calculated in percentages with triggers, okay, qualify, people who qualify, the trigger for being someone that qualifies for this issue of quality measure. Serving the triggers are the numerator, and then the qualifying resident are denominator. So like fractions, numerator on top, denominator on bottom. So you kind of figure out what goes where in your division process to get the percentage. And that's a little tricky when you look at these numbers too. I want to show you guys something that a few people have some hard times with about how these are reported. You got to remember percentages, because you have to do it's not a hard calculation, but a little calculation in your head to make sure you're getting it right. So let's quickly go over, and we're gonna pick up the pace here a little bit. Quickly go over which ones are kind of in here. So the percent of short-term stay residents who have an outpatient emergency room visit. So if someone goes back to the hospital for an emergency room visit, they're going to count in here. People who are rehospitalized after they get rehospitalized after their nursing home admission. So if they come to the nursing home, they get sick again, and boom, they're back at the hospital, which all of us, we all know that that's not something we want. But, it happens, and now you know how it's going to impact. Number of hospitalizations per 1,000 long stay resident days. And some of these are actually not percentages, now that I think about that. They're actually just a value, but we'll go over that, and I'm going to show you the difference in a minute. Number of outpatient emergency department visits per 1,000 long stay resident days. So number of emergency department visits per 100 days over a bunch of patients, or I'm sorry, 1,000 days over a bunch of patients, long-term care, long stay resident patients, which is over 100 days. So basically they're looking for percentages, and since we're talking about so many billable, since we bill in days, it just ends up being a lot. So if you have 50 residents, for a month, it's 30 days a piece. You get that PPD, payment per day. They're just kind of knock down some of these numbers, make it easy for you, so they're not this long when you try to figure them out. Discharge to community, successful return to the community. That's a positive one. All right. And now the short stay measures, we continue with these. I'm going to tell you exactly, and you can use this as a reference. I'm going to cruise through these because I don't need to read you guys sections and item numbers. If you're really interested in which sections attached to these measures, just print this, look at it, and go that way, because you're never going to remember. It's too much stuff to remember nowadays. We need reference tools, and I'm glad those things are available to us. But okay, so percent of residents with pressure ulcers, and that is going to be section M, and then you can see the other items where they fall. Percent of residents who are new to antipsychotic medication, section N. Percent of residents who have made improvement in function, also called residents who've improved their ability to move around their room. That's what they call it in some of the other documentation manuals and some of the guides we've seen. And that basically means someone who is recovering and getting better and more independent. And that's section G. Now, right now it's section G. Will it be GG eventually when they finally do make this big change and remove section G? I don't know. I'm saying yes, because I don't know where else they would get it from. So they probably will move it over to section GG, but as of right now, it is still section G, okay? Percentage of residents, one or more falls with a major injury. Falls is always a big deal. That's in your section J. High risk or unstageable pressure ulcers. Let me just touch on that really quick. Unstaged wounds, you need to keep a real close eye on those. I've seen and talked to some people. It puts you in a whole different category when it becomes unstageable. I'm not sure how it got to be a lot, but I've been in buildings lately where most of them are unstaged. I don't know if it's a wound doctor issue, wound nurse issue, but I would really push to get your wounds staged so you kind of know exactly where they are. Because even with the MDS, quality measures, even some reimbursement things, unstaged wounds could lead to bad stuff if you really don't get a new idea or a new plan for those. And some are unstageable. I mean, let me just say that too. There are some, but if you have a lot of yours coming unstaged because your nurses are trying to stage them, or they're getting a stage over the phone from it, you may want to try to at least invest for a short period of time. I'm not a big person on a lot of vendors and buildings, but at least for a short period of time, someone that can help you with wound staging and wound care in general, I should say. Percentage of residents with urinary tract infection, that's in I, and the urinary numbers are here. Again, I'm not going to read all these guys. It's not worth it. You can read. Percent of patients who have a catheter inserted and left in their bladder. Where else would you leave it? Just kidding. Some people get them and back out. Long term, it's more of an issue, and we know that. Percent of residents who need help with daily activities has increased. Okay, so what they're saying is patients that are getting worse in function as a therapist, you kind of do a double take on those when you see high percentages. Shouldn't be happening. If they are, contact your rehab people or your rehab company if you have one, and make sure that they get a handle on that. You're losing out not only on some appropriate Part B billing. Remember I just said that. Some appropriate Part B billing, but you're also going to have some falls, some more accidents, which again will affect other things. So make sure you get a handle on if you're seeing this one really start to change. You really need to get a handle with your therapy department. Percentage of residents who have an antipsychotic medication, same thing as a short stay, but this is long stay. Percent of residents who ability of move is worsened, again, same as section G. Okay, so when you get all these percentages, and we're going to go over exactly how that works, but basically what it is, who's eligible, pretty much most people are eligible for these in your facility. There's very few exceptions for people who have certain conditions where they're just not expected, or they are expected to worsen, but most people are eligible. And you said, you don't make it more complicated. It has to be, hey, everybody should be getting better in our buildings. No one should be getting worse. I just keep that going through my head. It's not worth taking out the few exceptions to get through the weeds. There's weeds out there, but there's also tons and tons of grass. So most of our residents are going to fall in these categories where they're going to be able to get scored. So I wouldn't waste a whole bunch of time figuring out who doesn't. Just focus on the people who are changing, okay? Anyway, so you can get this scale that I'm showing you here. I only took one example. This is just 2 of the quality measures, but you can actually get your what they have determined as the grid, or what they have determined as the cut points for how they score the quality measures for the 5-star rating. This is actually in that technical manual that CMS puts out for people to use every year. And they actually give you these in the appendix in the back. So you can use this to kind of grade where you are based on the percentages that you're seeing in your facilities. So you just look, very simple, percentage of short-term care residents who are rehospitalized after a nursing home. If you're between, and here's where that percentage thing comes up. You see like a 0.1771. 0.1%, that's not very much. Well, because of the amount of data that gets transferred from this place to that place, of these big pivot tables of Excel files and all this information that you download and export and zip and blah, 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 they like to keep things consistent. So they just keep the values, and then you just have to convert it to a percentage, which is very easy. You move the decimal place over a couple places, and that gives you your percentage. So it's not a hard calculation. Obviously, percent is on the 100th decimal point. So if you have a decimal point, move it 2 steps to the right, that's a percentage. It's just like you're putting the number over 100 and multiplying it out, or dividing it out, I guess. That's how that works. And when you first see these, a lot of people are confused because they think that's the percentage, but actually that is the value that turns into a percentage. And that can be a little confusing to people, but that's how that works. Same thing, with the ICD-10 codes. When you kind of go put it in some of their lookup Excel software, you don't put in the decimal point, you just put all numbers. Same idea. They're just trying to make it universal, simple. The less things that have to be translated on different platforms, the less mistakes you have. Give the raw numbers, give the values. It's very easy to know what a percentage is. So that's how that works, in case you get a little confused when you see that. All right? So let's do a quick one here, all right? Once the number of points are calculated in each quality measure, they're totaled, okay, both within their individual long and short stay buckets, and in total will determine your overall. So just like with nursing, right, you had your RN and your total nursing staff, you have your long-term and your short-term quality measures. Combine, boom, you get one big score. All right. Here is how the thresholds, or the matrix, the cut points, I guess they call it, works for those. So if you have 200 for long stay quality measure rating thresholds, you're going to fall within that 1 star. If you have 1,000, you're going to fall in that 5 star. That's all that means. And that is based upon, if you went back and looked at that grid that I showed in the appendix in the back of the 5-star technical manual, you will get your percentage. You go across, it will tell you how many points you get. You get that for every one of your quality measures. You add up the points, and it's going to drop you into a category. But there is a little bit of a calculation thing to level that out for short-term and long-term, which I'm going to show you in a minute. But you get your N number, and that's where that gets lined up against that. So let's do a quick example here. Again, these are quick, guys. You can go back and relook at this, do whatever you need to do. We look at it. So here's your short stay, all right? We have our first 6. I put MDS. You see 1 MDS, 2 MDS. That's a MDS quality measure. The CB is your claim-based. So I wanted to differentiate that just as a little reminder, okay? And then you look at your facility percentage. I'm talking a lot. I'm losing my ability to move my mouth. You get your percentage, okay? And then you line it up to the points that are in that range of the percent you fall in. So you look at the back of that appendix page in the technical, or some software, or a grid that some people, they have little cards, people print them out and stuff like, maybe we'll make some, I don't know. So 1.79 or pretty much 1.8% will be 80 points out of 100. And every one of these is either going to be 100 points or 150. And it's based upon the different levels you could fall into. there's really no other way to explain it. If you have a longer range and more people fall into different ranges, they give you a little extra points to kind of level this out. So it's either going to be 100 or 150 points. That's going to be your max. And then you determine how many you got based upon the percentages you got. Now, in 1 second, we'll go over that multiplier on the bottom. Probably should have flip-flopped these and did them the other way. Long stay, same way. There are the additional long stay, MDS, claim-based. You go ahead and see how they're labeled. You get your percentage or number. Long stay has number. If you see, I actually bolded it for you. Percent of residents experience one or more falls with major injury. Then if you go down towards the bottom, you say number of outpatient emergency department visits per 1,000. So that isn't a percentage. It's actually an average number. So out of 1,000 long-term stay days, we had 0.85 people go to the hospital. Does that make sense? Because we're talking about a lot of numbers here. If your average was 1, it means you had 1 patient or 1 resident every 1,000 days. This is a little under 1, so this person's under 1, which is not bad, you know. So that's why they get a 90 out of 150. So again, you line it up on those grids in the back of the manual, or the technical manual, I think they call it. You line it up, line those things up, and you get your score and total them up. For long-term stay, it's easy. Total them up. Total up your scores that you got out of whatever is available. 40 out of 100, you take the 40, the 60, the 40, the 60, the 75, 75, 90, 90, 90, come up with 620. Now, for short term, what they tried to do is in math, everyone, you got to balance both sides of the equation, right? That's the way math works. Just like your kids, when you give them Christmas presents, everybody's got to get the same amount. Billy can't have 10, and Jimmy has 6. You got to balance them out somehow, so you get them some other gifts. That's good now. You know, the only thing I could really think of. So you got to balance these two things out because they wanted them to weigh the same. They didn't want long stay to become more important than short stay, but they felt like short stay, these were really the most significant things they wanted to get a handle of. But even though there's a less in number, they're still as important. So in order to balance those things out, they use a multiplier. And in math, you would take, again, balancing both sides of the equation. So what they do is they take the total points available divided by the total points that you would get on the other, with long stay, you divide the two, right? The short stay, long stay, total points available, you divide the two, it will give you an adjustment factor, right? That happens to be 1.4375. So you take your short stay total, multiply it by 1.4375, and you will get a normalized adjusted weight. So now both of these are weighing short stay, long stay. You know, they're both worth the same amount because now they're at the same point value, and you put those two together to get your final quality measure score. That's the way it works. They could have just picked, I don't know, 3 other short stay ones, I guess, but this is how they chose to do it. So for in this example, when you look up the rating system on the little template or little chart, you would see long-term, long stay, 3 stars, short stay, 5 stars. Okay? That's how those things get out. Now, how does that average out? You don't have to worry about averaging those two out. What you do is you total your points on both sides, and that will give you your final score. All right? So we'll go through the example really quick here. Short term, long term, 755, 620, total 1375, right? Where's 1375 here? Here we go with our long. Here we go with our short. 1375 falls right there in the 4. Makes sense, right? One was a 5, one was a 3, 4 is in the middle. Happens to work out. Sometimes if you're on the fringe, most times this is kind of how it will, just because math and the ranges are pretty percentage-wise pretty similar, but there are some situations if you're on the top end of one and the bottom end of the other, you may lean towards staying on the lower score, you know, and that's just the way it is. So it's not really like 3. If they're both 3, you're probably going to fall on 3. You know, everyone knows that. But when you have separate ones like the 3 and the 5, who knows? Should it be 5? Should it be 3? Should it be 4? Take all that out. All you got to do is add those two numbers together and line it up in your overall. Now, it's nice to know where you are with each one. I would like to know where my short stay here, short stay did really well, long stay didn't fare so well based on their ranking system. You would know you have a little more time to focus on your long stay. So if you're already 5-star with your short stay, you're doing pretty well in Medicare's eyes as far as your care. So I wouldn't, you don't want to spend an exorbitant amount of time on your short stay stuff because it's already at the level they think. To focus on your long term, so that's why they want to keep those two things separate. Where your focus needs to be. Hey, they could be both 3. And you're both trying to go for a 5. Could be 2 in a 5. I don't know. It could both be 1s. It would be bad, but at least where you're headed with each one of them. All right, so got all that. Everybody's happy. We got our staffing. We got our survey. We got our quality measures. Now, how do we get the final score? We got these 3 pieces. We kind of know where we're sitting, but where are we going to end up at the end of the day? All right. So this is, remember what I said, the base. This is how you do it. You start step 1. You take your survey, your annual, your health inspection star rating, your base. That's what you're starting with, right? You add it, okay, based on your star rating. You are going to be the same. You're going to add or you're going to deduct. So you start with your base, you hit it with your staffing, and based upon the correlation between those two, it's going to let you know if you need to add or subtract or stay the same. All right? So that's why this survey is so important, because this is where you're starting. This is your start. Okay? Now, if you are a 5 or a 4-star for your staffing, and that is higher than your survey, you get another point. You get a bonus. You get to take your survey up. It goes up. All right? Now, if your staffing star is a 1, and remember what we said earlier, if you don't report, if you miss the 4 days, if you don't comply with an audit request to verify hours, you're automatically a 1, right? So say you busted your butt to get a 4 on your survey, somebody forgot to turn in your staffing hours, or an RN called in sick a couple of days and you couldn't find anybody, now you just went from a 4 to a 3. You're already going the wrong way, and you're deducting, which is not even saying the same, man. You're deducting. You're losing points, okay? You don't want that. Then you add, same deal, hook it up with your quality star rating, right? If you're 5-star for your quality star rating and your survey isn't a 1, you get another point. Add it up there. Now, if your facility quality star rating is a 1, boom, now you got to take another point away. You're sucking your points out. So you don't want a 1 for your quality rating either. So again, go back to your base, adding your staffing, adding your quality measures, and based upon how you do on those 2 things, you're going to go up or down. And that gives you your overall. Now, at no time can you exceed 5. This is a 1 to 5 rating, and you can't go under a 1. So you can't come out 6. Oh, I got a 6, guys. Holy cow, we had a great time. No, you didn't get a 6, because 6s aren't possible. You got a 5, though. That's great. I wouldn't worry. Good as a 6. Or you can't go under a 1. And again, if you're teetering on falling under a 1, you got a lot of other problems than your 5-star rating. You have some care issues, and you need to make sure your residents are taken care of. Okay. So here's the quick example of that. You got your survey, star rating, 3-star. Yay, we're all happy. We did 3-star. We didn't get that. But that's your base. You're starting out with that. Remember, that's 3 years back. So there may be something lingering back there in 2018, 2019 that didn't go well. Somebody forgot to do something, or you just got a big tag because of a patient and a situation that came up. So you're still trying to overcome that. Your staffing is a 4. Awesome. We get another one. So now our 3 goes to a 4. We're at a 4-star. But your quality star rating got a 1. It stunk. Excuse me. So that was an issue. You lose a star. Your end rating would end up being a 3-star because of the rules of how you add and deduct a point. You can't total them up. I mean, you only have 5 stars that you're kind of dealing with here. So totaling them up or subtracting. It just doesn't work with 5. You have 3 components and 5 total stars. It's only you only can go so far either way. So it's based upon your base, survey, annual, and then the other 2 components after it, add, subtract, or stay the same. Okay. So one thing you have to remember, if your health inspection rating is only a 1, all right? If your health, and this is where you might be getting close to our special focus folks that have a real hard time getting out of, by the way, but if your survey, again, I always said it's the most important, if your survey is a 1, you can only go up 1 more. You can only go up to a 2, regardless. That's as high as you can go. All right, and how it's worded is if a health inspection rating is only a 1 star, overall rating cannot be upgraded more than 1 star on staffing or quality. So you're stuck. It's a limiting, very, very limiting factor for you. Now, if your facility either is a 5 or 4 star rating goes up higher, this is kind of explaining, then if your penalty star for your facility is if you have a 1 for penalty, and it's the same thing. So there's other scenarios. This is just my example, and I wanted to level those out for you, but you can go through the other examples, and it'll tell you how to add and subtract, There's some rules to those. Now let's go over some quick exceptions. Facilities with a history of severe abuse citations have their overall star capped at 2. 2 seems to be, 1 and 2 seems to be the magic number. If you are struggling with a lot of issues, you are not getting over a 1 or 2. It's just not going to happen. You got to get past those issues before you start moving on. Those facilities that are too new to have a survey rating will not reflect an overall rating. So, and that's kind of fair. If you don't meet all these qualifications, if you just started, you've only been around for a couple months, and the quarter ends, you're not going to get some weirdo score just based upon a low level of patients. You're going to wait till you get a full cycle quarter, then you get your official 1st star. Now, facilities that have been designated as special focus facilities, and this is new, I think, the last, 5 years or so, I can't remember. But if you're in the special focus group, you don't even get a rating anymore, man. I mean, you get nothing. You get I think you get like a red something, either a hand or like exclamation point, and you don't even get it, So you are known to be the worst in your area or your state. Now, being that low, again, your main priority probably isn't your 5-star rating. Your main priority is probably not losing your provider number. So if you are in this category, you definitely have other things to work on. But when you start getting out of them, you definitely want to get this up as fast as possible. And that's always tough because the surveys go back 3 years. It makes it very difficult. But facilities that are in this category have had very, very serious concerns with jeopardy, widespread jeopardy, things that are very unsafe, and Medicare is going to handle those, and they're going to make sure that they get back on track. So it's just something that they use to indicate those places that are in, I call, a rebuilding period, just to let people know, hey, you come in here. We're definitely working on stuff. We're getting things better. I try to be positive about it the whole time. I'm not saying they're horrible people, a horrible place. Just saying they had some stuff that they need to get fixed and get handled. You might not want to be in here because there's some things that we're still trying to figure out, and we don't want to have anybody else, run into a situation that we're having with some other people that we already had. It's just a little warning to people. Hey, if you still, they can still go there though. I mean, it doesn't necessarily mean you're closed to admissions. There's other processes in place that assure that your admissions are still going to be safe, but it is going to be a warning that's out there. Now, how many facilities qualify for this? Again, it's weird because it is on that sliding scale. In some states, they might not have any. There's a few states, and I'll have to look at the map, but you can look at, I think there's a few states that really don't want to have any because of the low amount of nursing homes they have. So these are supposed to be like the lowest of that 10%, like that bottom 1% will get the label of a special focus facility because they're not picking it up like everyone else is, okay? And they have these lingering issues, and they can get, kind of stuck there. So it is still based upon a sliding scale, but most of those buildings have some pretty significant things they need to work on where they're not shocked by this. And the allegations or the situations they had are things that definitely need to be handled and addressed. So I still think it's an okay system. I still think it's kind of fair. Personally, I would think for a focused facility, maybe the sliding scale is tossed out and it's just based upon a criteria of bad situations that happened. Because if everybody is really, really good and everybody's a 5-star, is a 4-star going to become a special focus? And I doubt it. That probably never happened. But I'm just saying, for argument's sake, that's kind of what you're saying. So, I don't know. It hasn't been around that long. And again, those buildings that have fallen into this, we're not shocked that this was where they fell. So, I think it's okay for now. But, just if you're really in any threat of falling in that category, you definitely have some work to do. You're going to need some help doing it. All right. So now, how do you improve this stuff? A lot of the stuff, you're just kind of looking at numbers. Number one, survey readiness, man. I'm telling you, this is the base. Survey readiness. Have some mock surveys. There are companies that will do them. There are accounting firms that will do them. There are people you can hire that may even be able to do them themselves. We've helped people do these. All the survey training, survey protocols are available from CMS, so you kind of know what they're looking for. And everyone's kind of known that for a while. You got to get your survey stuff ready. Train your people. Put some effort into training your staff to make sure they understand this process and how important it is. I see so many facilities get in their survey window and they go in this panic mode. They're running their building like a totally different operation. You should be ready for survey any day, every day. It should matter that you're in your survey window because you should be running like you were in it every day. And if you do it that way, you're less likely to run into an issue. Short stay measures. Okay, remember that weighted system we talked about? How the long stays were more, and then we had to use this multiplier? What does that tell you? They weigh heavier. If you have less things to fix and focus on, the weight is heavier, you can improve your star rating quicker. Okay, short stay measures are a great way, and there's a calculation. They contribute 44% more points to the overall star rating. That's a huge bump. Okay, number 3. PDPM coding, proper PDPM coding. PDPM coding under this new PPS system is great for making sure you're moving forward with quality measures in coding and in care in general. It's a really, really good way. You focus on PDPM, not only will you get reimbursed for what you deserve, but your quality measures will improve, and so will your 5-star. MDS coding is ultra important right now. And whoever's doing it needs to know what they're doing. Therapy, nursing, social service, they need to do these things right. It's critical now that these MDSs get correct. And I gotta give a shout out for what we've seen. Many JMD Healthcare had something out there about how people are getting better at MDSs, and we see the same. I was watching it. It was some summit for Skilled Nursing News or something. They were almost word for word what we were seeing as far as people just improving organically. When we first started doing when PDPM started, I was like, oh my gosh, how are they missing all that stuff? Well, over the last 6, 7, even during COVID, 6, 7, 8 months, they have gotten drastically better at coding their MDSs, and that's a really good sign. Good sign. RN staff hours, again, don't screw up your score with your RN staff hours. I'm telling you. Some people may only have a few RNs coming in weekly. You got to get a handle on them, make sure those things are covered. You don't want to screw up your staffing that way. Never forget to report. That should be a no-brainer, but don't do it. And track your progress. I mean, it may seem like this is super complex, but if you get the key components down and you know what are the key areas that are going to hurt you, it isn't hard to determine if someone is going to go up and down. There are tracking sheets that people offer. There are little software programs, Excel programs that you can help track your own patients and who's qualifying just on an average. And there is a mathematical calculation of this that can actually tell you if you're heading in the right or wrong direction. And there are many software systems that are now integrating this into their, because it's right off the MDS, right off your claims. Data's there based upon your census, based upon how many percentages you're seeing go in one direction or the other, how far away you are from the next threshold. It is not really hard for someone who gets this to tell you, hey, you guys do 10 more patients over the next month that are in this percentage for this measure, you guys are going to go up. That is not, you don't even need an Excel program in some cases to even figure that out. So tracking your progress is a great way. And what does tracking your progress do? Accountability. You hold yourself, your staff accountable by constantly tracking and documenting things. That's how people are held accountable. Okay? Now, COVID, really quick. I'm sorry this is taking so long. There's a lot of information here, and I get really excited about it. I kind of like this whole idea of it. But with COVID, on January 27th, 2021, nursing home 5-star rating was updated for the first time to reflect survey data from 2020 during the pandemic. It was on hold for a while. The 5-star was held constant for most of 2020 so people could focus on the residents and their needs and infection control. Now, another little funny thing that actually made these slides before I found out about this, but they weren't going to take into consideration some of the infection control surveys that they had, and they kind of changed their mind on that, and they did add some of these into the survey ratings because they felt like they were very important, and that kind of shows you this is going to be an ongoing thing, guys. This infection control is going to a new level. If you don't have an infection preventionist in your facility, you should, or you should maybe have one that is going regionally or somebody that's overseeing it. You need to have this in place. Don't forget about it when this COVID thing's over and everyone's vaccinated. Don't forget about this stuff. They're going to come back. They're going to recheck it, and they're not going to be gentle on the fines and the penalties with this, is what I heard. This is a serious issue. They were very concerned about the level of deaths that we've had in our facilities. It's unfortunate that this current current virus attacks the elderly, makes them the most vulnerable. That's unfortunate for us in our industry, but it is what it is, and it's something we have to deal with. Infection control is going to be a focus for a long time, I promise. Okay? Okay. But the good news, all right? Long-term stay depression worsened 5 to 6%. So it wasn't that much compared, in relation to what was going on, not seeing families, not seeing friends, people around, your friends dying, people around you dying, a very stressful situation going on. The stupid news that people are watching, don't watch it by the way, all that was very hurtful mentally, I think, to people. But to only see that 1% go up, plus, honestly, people have been scoring this a little bit better on their PHQ-9s, we've noticed, when doing our audits. So that could be a product of that also, but not a huge, so we're taking care of residents, we are being attentive to their needs. If that would have went up to 20%, I think that would have been a problem. So great, that was a great job. Long-term K mobility worsened, only less than, let's see, a little over 1%. There was a lot less therapy. People were not able to go outside. People were not able to go to outings. People were confined to their rooms. All that stuff was going on. Very little impact there, very good. People were very, again, conscious of people. And short-term functional improvement improved to 69%. People are probably trying to get out there quicker. But so we did see some good stuff there. So I think all those are very positive for our industry. It's such a horrible thing that happened in our facilities and to our residents and to basically, without them, we don't even have a profession. I think it's a very good indicator of how well, regardless of what the news says, they really put a bad perception on us a lot, but regardless of what they say, how attentive we are to our patients' needs. And I truly believe that. I truly believe people work at nursing homes because they care about them. It's a hard environment to work in. It's a hard population. Trust me, if you didn't like them, if you didn't care for them, you wouldn't be there, man. I'm telling you. You just wouldn't. So, people got to get over that, but we have to do our part to make sure we get a little more recognition for all the great stuff we do, and people get off the bad. The news. That's all they talk about. So whatever. But I'm excited about getting past this, and I was excited to see those numbers. It's very, very, very encouraging. So, if you want to look at a timeline here, if you look at the overall star ratings back to 2008 and 9 to 2021, didn't see a huge shift in it. The two giant drops you see were due to changes in the scoring system. 2015 and then 2019, they added the RN stuff and a little more, made things a little bit tougher for us then. But we've gotten over that and we've curved back up. And when you look at 2020 to 21, don't see a huge drop in star ratings, which is a really good sign. I mean, some people did just because of the situation. Some people got better. But overall, our industry did a fabulous job taking care of our residents in the worst circumstances possible. I could not even think of anything worse. So I think we need to give ourselves a little bit of credit on that end also. So if you have any questions, again, John Delossantos, JMD Healthcare. We are a skilled nursing facility management service. We specialize in both therapy operations, auditing, 5-star, quality measures, PDPM, all the way across the board. We are looking to bring a whole new level of understanding and spreading that understanding among multiple disciplines and get some of the barriers that have been between nursing and therapy for years, with the contract therapy model, and that's a whole other story. A whole other conversation we could get into. But if you ever need any questions or any concerns, please let us know. If you have any suggestions on any future webinars that you feel like will be beneficial to you, definitely let us know. We're always available to answer questions, always available to give free initial audits. We love this stuff. We've gotten very good at it. So again, reach out. Never settle for something you don't feel like that you feel like could be better. I mean, I see a lot of people do that, and I think our industry needs to get past that because that's gotten us stuck in a few situations. So reach out. We're always available. We love doing this stuff. That's about it. Hey, again, any questions, fill them out on the page here. We'll get those answered for you. And I hope everyone has a great recovery from COVID, and I hope everyone has a great rest of their week. Thank you. Take care.